Good morning, everyone. Myself, Dr. Niharika. Arya. I'm an assistant professor in the Department of Ophthalmology. So today I'm taking an topic on community ophthalmology. Okay. So what is community ophthalmology? So it's a community ophthalmology. Is it? It's a type of clinical health in which there is a use of appropriate strategies and method to reduce the burden of eye disease in a community. Okay, so it isn't what is so it is a use of appropriate strategies and methods to reduce the burden of eye disease in a community. So it is an ideal healthcare system. It combines the equity and with quality. Okay, so it combines. It's an ideal healthcare system. Community ophthalmology. It's an ideal healthcare system which combines the equity and with quality of the quality of the health system. So healthcare efficacy in terms of optimal utilization of infrastructure and time is a moral responsibility in a resource-starved country. Okay, so in community ophthalmology, the 3 E's, that is the 3 E's, that is excellence, efficacy, and equity, thus have high ethical relevance in the practice of the community-based ophthalmology. So in the practice of the community ophthalmology, the 3 E's is very important. The 3 E's stands for excellence, efficiency, and equity. Okay, so it is community ophthalmology. Okay. So the basic principle, the practice of the community ophthalmology involves first an assessment of the extent of the problem of the eye disease and the socio-economic impact of blindness in the community. Okay, so and the second principle is finding and applying the most appropriate eye care solutions for the specific community. So these are the two basic principles in which the community ophthalmology is based. That is the practice of the community ophthalmology. It involves an assessment of the extent of the problem of the eye diseases and the socio-economic impact of blindness in the community. Second, finding and applying the most appropriate eye care solutions for the specific community. These solutions comprises of the first is the preventive activities for control of communicable and the non-communicable eye diseases and environmental health hazards. Second, it's promote activities concerned with the improved nutrition, intensive healthcare education, and improved lifestyle. Okay, and third, it involves the curative problems addressing the common eye health conditions like refractive errors, glaucoma, cataract, xerophthalmia, etc. So these are the three solutions which comprises of the community of ophthalmology. It includes the control of communicable and the non-communicable eye disease in the community. Second, is promote the activity concerned with the improved nutrition and intensive eye health care system education and improve the life health. Third is the curative problems, addressing the common eye conditions like the refractive error, glaucoma, cataract, and xerophthalmia. Blindness. So what is blindness? So blindness is divided. It's of many subtypes. First is the economic blindness, that level of blindness which prevents an individual from earning his wages. So this type of blindness in which that prevents an individual from earning his wages, that is presenting vision of less than 6/60 in the better eye. So if the vision in the better eye is less than 6/60 and which hampers the day routine activity of a person, that is known as the economic blindness. Since this level of visual impairment hinders a person from earning, also referred as the work vision. Okay. So what is economic blindness? A blindness which hampers the day routine work of a person, or difficult or help or hinders a person from the earning, is known as economic blindness. And the vision in the better eye is less than 6/60. It is known as economic blindness or the work vision. Second is the legal blindness, the level of blindness that necessitates welfare measures and the legal protections. Okay, that level of the blindness that it itself needed some welfare measures or the legal protections. Okay, excuse me, the vision less than 6 by 60 or less than or less, a vision less than 6 by 60 or in the better eye with the correction, or a visual field less than 10 degree. This is known as legal blindness. This definition is used in USA. Okay, so legal blindness means actual the patient is blind and it needs something like certificate or anything that from the government, need any help from the government resources, so that they can do their so that they can be so that it can be welfare measures. Okay, it's a vision less than 6 by 60 or less in the better eye with the correction, or visual field less than 10 degree is known as legal blindness. This definition is used in the USA. Third is the social blindness, the degree of disability that hampers an individual from socially interacting with the families and peer groups in a satisfactory manner. So, social blindness means the degree of disability, the degrees of the disability that hampers an individual from the socially interacting with the families and peer groups. The inability to count finger at a distance of 3 meters with the better eye with best correction. Since this level of visual impairment curtails the day-to-day movement of an individual, also referred as walk visions. So, this type of social blindness in which the person's vision is very less. So, the vision of that is only at the level of the counting finger at a distance of 3 meters only, with the better vision and with the best correction only. And with the best correction also, their vision does not improve more than 3 meters. So this is known as social blindness, and it helps the individual, and it helps the level of the blindness hampers the day-to-day movement of an individual. So this is known as also known as the walk vision, and the vision which hampers the day routine work is known as the that is known as the work vision, and the vision which day-to-day that hampers the day-to-day movement of an individual, it is called as a walk vision. So this is known as a social blindness. Manifest blindness, if the vision of a person is less than 1 by 60, seriously constant the accomplishment of tasks for daily living, also impairs mobility, used as service indicator, as most of the cataract blind in the developing worlds are operated at this stage. So manifest blindness is actual because of that is a blindness which has a vision of less than 1 by 60, which which very badly hampering the task of daily living of a person. It also impairs the mobility of a person, and there will be any cause of that blindness. So like cataract, glaucoma, it's any cause of that blindness. So as a used as a service indicator, as most of the cataract blind in the developing world are operated at this stage. Next is a absolute blindness, the inability to perceive light in any eye. So this is the absolute blindness, or there is a complete blindness. That is, there is no any perception of any light in that eye. Curable blindness, that stage of blindness where damage is reversible by the prompt management. Example, cataract. So curable blindness means if there is any cause of that blindness which can be promptly managed. So this is known as a curable blindness. Preventable blindness, the loss of blindness that could have been completely prevented by institution of the effective preventive or prophylactic measure. Example, xerophthalmia, trachoma, and the glaucoma. So this is the loss of blindness. Preventable blindness means that is that disease that which causing the blindness of that eye can be prevented by the prophylactic measures or by any medical management. This is called as a preventable blindness. Example, xerophthalmia, trachoma, glaucoma. Avoidable blindness, the sum total of curable blindness. In India, 85 to 90% of all blindness is avoidable. Okay. Third is the incurable blindness, the state of blindness which is beyond redemption, that is 5 to 10%. Incurable blindness that cannot be prevented by any of the measures, like prevent by any medical management or by the surgical management. That blindness cannot be curable. So this is known as incurable blindness, which is of only 5 to 10%. According to the WHO, the definition of the blindness is accepts a cutoff of visual acuity of less than 3 by 60 in the better eye with the best possible correction to define the blindness. This is the definition of a WHO, which includes that if the vision is less than 3 by 60 in the better eye with the best possible correction, it's called as the blindness. According to the NPCB, if the visual acuity is less than 6 by 60 in the better eye with the best possible correction to define the blindness. Okay, these are the two definitions which quotes according to the WHO. He quotes that what is blindness if the visual acuity is less than 3 by 60 in the better eye with the best possible correction. And second, according to the NPCB, if the visual acuity is less than 6 by 60 in the better eye with the best possible correction. This is the two definitions given by WHO and the NPCB. What is NPCB? It is the National Program for Control of Blindness. So NPCB is the National Program for the Control of Blindness. It was launched in 1976, being implemented as 100% centrally sponsored program since its inception. Okay. In 1982, it was implemented with the Prime Minister's 20-point socio-economic program. So NPCB is the National Program for Control of Blindness. It's launched in 1976. The objectives of the NPCB is the provision of comprehensive eye care facility at primary, secondary, and the tertiary healthcare level. And second, to achieve a substantial reduction in the prevalence of the eye disease in general and the overall reduction in the prevalence of blindness to 0.3% by the 20,000. So these are the objective of the NPCB. It's to provide the comprehensive eye care facility at primary, secondary, and the tertiary healthcare level. And second, to achieve a substantial reduction in the prevalence of the eye disease in general and the overall reduction in the prevalence of blindness to 0.3% by 2000. So the component activities under what are the components, what are the activities under NPCB is creating an infrastructure for cataract, surgical and support services. So what are the components of NPCB? It includes, that is creating an infrastructure for cataract, surgical and support services. Second, school eye screening and the refraction services. Third, strengthening eye health education activities. Fourth is the control of corneal blindness, including the establishment of the eye bags. So these are the components which comes under the NPCB program. That is, first is creating an infrastructure for the cataract, surgical and for surgical support. Second, schooling, that is school eye screening and the refraction services. Third is the strengthening the eye health education activities. Fourth is the control of corneal blindness, including the establishment of the eye bags. As per survey in the 2001 and 2002, prevalence of blindness is estimated to be 1.1%. So rapid surveys on avoidable blindness conducted under NPCB during the 06 and 07 showed reduction in the prevalence of blindness from 1.1% to 1%. So various activities and initiatives undertaken during the 5-year plan under NPCB are targeted toward achieving the goal of reducing the prevalence of blindness to 0.3% by the year of 2020. So main cause of blindness are, first is the cataract, that is of 62.6%, refractive error 19.7%, then comes the corneal blindness, that is 0.9%, glaucoma 5.8%, surgical complications it's 1.2%, posterior capsule opacification is 0.9%, posterior segment disorder is of 4.7%. Other includes like any trauma or any congenital diseases, that is includes 4.1%, and the estimated national prevalence of childhood blindness and low vision is 0.8% per thousand. So these are the main causes of blindness, which include the first most important is the cataract, refractive error, then a corneal blindness or any congenital diseases, that is corneal blindness, and there is a glaucoma, surgical complications, posterior capsule opacification, posterior segment disorders, and the others. Three major types of refractive corrective which is to be provided to the population is first of the myopic correction for the school children. Second is the presbyopic corrections to the above 40-year. Aphakic corrections to the operated cataract patients. So myopic patient correction for the school children, generally the patients are myopic, and if the proper treatment of the proper glasses is given to that at the school level, then the chances of refractive error is decreased. Second is a presbyopic correction. Presbyopic correction is the loss of, what is presbyopia? So presbyopia means there is a loss of accommodation and because of the increase in age. Okay. So it is mainly above the 40 years. Aphakic corrections means in the case after the operation, if there is a any condition in which the intraocular lens is not placed, as already aphakia means there is an absence of any crystalline lens or the absence of any intraocular lens. Its condition is known as aphakia. So aphakic corrections to the operated cataract patients by giving any spectacles or putting on the secondary eye. What is the intensive health education activities like are central to the success to the NPCP. Health education activities like the school screening programs or the camps. These are the intensive health education activities. Information, education, and the communication activities have recently been augmented. Okay, so these are the three major types of refractive corrective which is to be provided. That is what are the most commonly important? That is the myopic corrections to the school children, presbyopic corrections to the above the 40 years of that of 40 years of persons, and third is the aphakic corrections to the operated cataract patients. What are the goals and objectives of the NPCP in the 12th plan? To reduce the backlog of the blindness through the identification and treatment of blind at primary, secondary, and the tertiary levels based on the assessment of the overall burden of the visual impairment in the country. And second is to develop and strengthen the strategy of the NPCP for eye health and prevention of the visual impairment through provision of comprehensive eye care services and the quality service development. And strengthening and upgradations of the regional institution of ophthalmology to become center of excellence in various subspecialty of the ophthalmology. So these are the goals of NPCP in the 12th plan. First is to reduce the backlog of the blindness by identification and treatment of the blind at the primary, secondary, and the tertiary levels. Second, develop and then strengthen the strategies of the NPCP, that is strategies of the eye health and prevention of the visual impairment through provision of the comprehensive eye care system and quality services. Third is the strengthen and the upgradations of the Regional Institute of Ophthalmology, okay, to become the center of excellence in the various subspecialties of ophthalmology. Strengthening the existing and developing additional human resources and infrastructure facilities for providing high quality comprehensive eye care in all districts of the country. Then to enhance the community awareness on eye care and lay stress on preventive measures. Increase and expand research for prevention of blindness and visual impairment, and to secure participation of the voluntary organization or private practitioners in eye care. So this also includes that is developing the additional human resources and the infrastructure facility for providing high quality comprehensive eye care in the district level, at the district level. And the community also enhance the community awareness on eye care, increase and expand researches on for prevention of the blindness, and also most important is to gain the more participations of the voluntary organizations or the private practitioners in the eye care. So these are some of the goals of NPCP. So what is corneal blindness and the eye donation? For this purpose, NPCP supports the establishment of the eye collection centers and eye banks both in the government and the NGO sectors. So the corneal blindness and the eye donations can also be treated for this purpose for the corneal blindness and the eye donation. So eye donation. Corneal blindness can also be treated by the surgical method, by the transplantations of an eye. So that for that, corneal blindness and the eye donation is very is necessitated. For this purpose, NPCB supports the establishment of the eye collection centers and eye banks both for the government and the NGO sectors. The World Bank assisted cataract control project was initiated in the for the control of the corneal blindness and the eye donation. The World Bank assisted cataract control project, which was initiated in the 1994, covers 7 states where the prevalence of the blindness and the backlog of operable cataract was the highest in the country, like UP, Rajasthan, MP, Maharashtra, Andhra Pradesh, Odisha, and the Tamil Nadu. In these states, over a period of 7 years, augmentations of the cataract surgeries was adapted. 11 million cataract surgeries were planned to be done. Second is the DANIDA support to the national program. The Danish International Development Agency has been assisting NPCB since 1978. The DPCS, that is the concept, was first successfully tried out by the DANIDA. Vision screening and the programs in school have also been pioneered by the DANIDA. In the current phase of assistance, DANIDA has adopted Karnataka as a pilot state and is funding all eye care activities in this state. Phase 3 of the DANIDA assistance is being implemented since 1997. Okay. So this is the DANIDA support of the national program. The Danish International Development Agency have been assisting NPCB since 1978. Okay. DANIDA is important. It has started in the 1970s. DFID assistance to NPCB. The Department of the International Development of the UK has been actively collaborating with the Government of India in strengthening community ophthalmology services. And this is the new, that is DFID assistance to the NPCB. That is, it includes the Department of the International Development of the UK. It's also been trying to collaborate with the Government of India in the strengthening the community ophthalmology services in India. What are the different organizations of the NPCB? First is the National Program Management Cell. Second is the State Program Management Cell. Third is the District Blindness Control, and which includes the District Blindness Control, which includes the district hospital and the district health officer, the district hospital like the medical superintendent, which have ophthalmic surgeons and the district mobile unit. And the second is the district health officers, that is the CMO, which includes the community health officer like medical officer or primary health officer. So now what is Vision 2020? The right to sight is a very important topic for your like in your sessions, as many questions come in this, right, Vision 2020. So be careful and be attentive during this. Okay, so what is Vision 2020? The right to sight is a global initiative launched by the World Health Organization and a task force of international non-government organizations. It combats the gigantic problem of the blindness in the world. It was launched in Geneva on February 18, 1999 by then the Director General of the World Health Organization, Dr. George Herman Brundtland. Okay, so this is a global initiative launched by the WHO and the Task Force of International Non-Government Organizations. Okay, so Vision 2020, the right to sight. And it was launched in Geneva on February 18, 1999. It envisages the collaborations between governments, WHO, International Agency for Prevention of Blindness, Funding Agency, international non-government and the private organizations that collaborate with the WHO in the prevention and the control of the blindness. Globally, 5 conditions have been identified for the immediate attention for achieving the goal of Vision 2020. So these are cataract, trachoma, onchocerciasis, vitamin A deficiency, and the other causes of the childhood blindness, refractive errors, and the low vision. So these are the 5 conditions which comes under the which needs an immediate attention for the achieving the goals of Vision 2020. So these are the what are the 5 conditions, that is the cataract, trachoma, onchocerciasis, vitamin A deficiency, and other causes of childhood blindness, and refractive error, and the low vision. So these are the 5 main conditions which which needs to be treated in the goal of Vision 2020. These conditions have been chosen on the basis of their contribution to the control of the burden of the blindness, and second, the feasibility and the affordability of interventions to control them. So these conditions, these 5 conditions is there, that is, it causes they are the more prone to cause the blindness in the community, and second, in the intervention to control them or intervention to treat them, the feasibility and the affordability is less. Is very easy. So that is the feasibility and the affordability of the intervention to control them is very easy. So each country will decide on its priorities based on the magnitude of specific binding conditions in that country. So these conditions are, why the conditions is to be chosen, because their contribution to the burden of the blindness, second, the feasibility and the affordability of interventions to control them. Under this initiative, 5 basic strategies to combat blindness are: first is the disease prevention and the control, second, training of the personnel, third, strengthening the existing eye care infrastructure, and fourth is the use of appropriate and the affordable technology, and third is the mobilization of the resources. Okay. So these are the 5 basic strategies is be planned under the Vision 2020 to combat the 5, that is the 5 main common cause of the blindness. First is the disease prevention and the control. Then we have to train that personnel, that we have to that at that place the trained person should be there, strengthening the eye care infrastructures to like affordability, strengthening the existence eye care infrastructures. If the cause needs any surgical interventions, then for that proper infrastructure should be there, use of appropriate and affordable technology, and mobilizations of the resources. So first is the cataract. So major cause of blindness in the world, an estimated 16 to 20 million people are bilaterally blind from cataract, and the number is also increasing. Cataract surgical rate, a quantifiable measure of the delivery of the cataract services. Number of cataract operations per million population per year. Meaningful to estimate only when there is an ample information on all cataract surgeries performed in a country, for example, including the private sectors. So, the cataract is the major cause of blindness in the world. The aim is elimination of the cataract blindness, that is, person with a vision less than 3/60 in the both eyes. Second is the trachoma. Trachoma is the most common preventable cause of blindness in the world. An estimated 146 million people have the active infection with the microorganism Chlamydia trachomatis, for which antibiotic treatment is indicated. There are approximately 10.6 million adults which has interned eyelashes, like tracheasis or the entropion, for which eyelid surgery is needed to prevent blindness. Okay, so trachoma. So trachoma is the most common preventable cause of blindness in the world. So in this, it mainly caused by the microorganism, that is the Chlamydia trachomatis, for which antibiotic treatment is indicated. In this, in trachoma there is an thickening of an eyelid because of the infection caused by the microorganism Chlamydia trachomatis, and because of that infection to the eyelid, and because of the because of the increase in the thickness of the eyelid, there is a turn in eyelashes, that in turn of the eyelashes, or there will be the misalignment of the eyelashes, that is a trichiasis or the entropion, for which eyelid surgery is needed to prevent the blindness. Because if in conditions like in entropion and in the trichiasis, because of the intern of the eyelashes that causes a continuous rubbing of an cornea, which leads to a blindness. An estimated 5.9 million adults are blind from corneal scarring due to trachoma. So, because of the because of that intern eyelash, because of the continuous rubbing of the cornea, because of because of the continuous rubbing of cornea by eyelashes, it leads to corneal scarring. Trachoma is the second cause of blindness in the sub-Sahara Africa, China, and the Middle Eastern countries. Trachoma is to be controlled through the implementation of the safe strategies integrated within primary healthcare in all the communities identified as having blinding trachoma within a country. So it is very important to control the trachoma. Antibiotic treatment is named, but the complete protocol of controlling the trachoma or the strategy to control the trachoma is known as the SAFE strategy. SAFE, state strategy. So what is safe strategies? Is first is the assessment of identifying the community with the blinding trachoma, delivery of the community-based trichiasis. Okay, that is surgery by the trained paramedical staff. So S of safe stands for the surgery. The surgery of surgery of eyelashes, surgery of eyelid, surgery of cornea. Because of that cornea scarring, you need an transplantation of an cornea, or like in the case of trichiasis or the when you need an eyelid surgery. So surgery S of safe stands for surgery by the trained paramedical staff. Second is antibiotic treatment, either tetracycline eye ointment or the oral azithromycin for children with active disease. So A of SAFE stands for the antibiotic treatment. Promotion of facial cleanliness. So F of SAFE stands for the facial cleanliness. Environmental improvement. E of SAFE, including the personal hygiene and the community sanitations as a part of primary health. So E stands for the environmental improvement. So this is the SAFE strategy. S stands for the surgical implementation, surgery. A stands for the antibiotic treatment like tetracycline or the oral azithromycin. F stands for the facial cleanliness, and E stands for the environmental improvement. It includes the personal hygiene and the community sanitations. It aims the elimination of the blindness due to the trachoma. Okay, so this is the trachoma. Now comes the onchocerciasis. An estimated 17 million people are infected with the onchocerciasis. Approximately 0.3 to 0.6 million are blind from the disease. Endemic in 30 countries of Africa and occurs in the few foci in 6 Latin American countries and in Yemen. Elimination of the blindness due to onchocerciasis. So it is a parasitic infestation. Onchocerciasis is a parasitic infestations of parasitic of onchocerciasis, which causes the blindness. Childhood blindness. The main cause of the childhood blindness are vitamin A deficiency, measles, conjunctivitis of the newborn, congenital cataract, and the retinopathy of prematurity. So these are the main causes of childhood blindness, which includes vitamin A deficiency, measles, conjunctivitis of the newborn, congenital cataract, retinopathy of prematurity. Estimated 1.5 million blind children in the world, of whom 1 million live in Asia and 3 lakhs in Africa. Prevalence 0.5 to 1 per 1,000 children aged 0 to 15 years. An estimated 5 lakh children going blind each year, that is 1 per minute. Many of these children die in childhood. It is estimated that childhood blindness causes 75 million blind years. That is number blind into length of life, second only to the cataract. So the childhood blindness is very important. Childhood blindness, the curation of the childhood blindness is very important. So an estimate like estimated 1.5 million blind children in the world, of whom 1 million live in Asia and 3 lakhs in Africa. So an estimated 5 lakh children going blind each year. It is 1 per minute. So these are some of the places other than India, outer like Africa. The major cause of blindness and the childhood blindness in the Africa is a corneal scar or corneal ulcer because of the measles and the vitamin A deficiency and the harmful traditional practices. Second is the congenital cataract and the hereditary disorder. In Asia, the major cause of childhood blindness is vitamin A deficiency, congenital cataract or rubella, or hereditary retinal diseases. In Latin America, the major causes is because of the congenital cataract and the glaucoma, rubella, or the retinopathy of the premature. In the industrialized countries and the urban centers, there is a retinopathy of the prematurity, congenital cataract, or the hereditary disorders. So these are the major causes of the childhood blindness in the different places of a country, in the different places in the world, like in Africa, Asia, Latin America, and industrialized countries and urban centers. Now come the refractive errors and the low visions. Spectacles are an essential part of the treatment of the many eye patients. Their provision is therefore an integral part of the eye care delivery. Okay, so the refractive errors and the low vision is also the cause of the blindness if the appropriate treatment is not given at the correct time. Okay. So spectacles are an essential part of the treatment. Their provision is therefore an integral part of eye care delivery. The steps in the provision of the refraction services and low vision care of patients are as follows. First is the provision of the refractive surgery. The first step is for the screening. In the screening, it includes the identification of individuals with poor vision, which can be improved by spectacles or the other optical devices. Second, by the screening, we have to screen the every individuals with a poor vision, which can be improved by the spectacles or the other devices. Second, by giving the refraction, that is evaluations to the patient to determine what spectacle or device may be required. Third is the manufacture. It is the manufacture of the spectacle or an appropriate device, both of which may be manufactured locally or purchased externally or can be donated. Third is the dispensing. Issuing of the spectacle or devices, ensuring a good fit to the correct prescription. And fifth is the follow-up. That is the repair of the spectacles, devices, or the repeat dispensing. So these are the steps. For the provision of the refractive services. First, we have to screen the patients. We have to screen the community, or to identify the individuals with the poor vision, which can be corrected with the spectacle or with the other devices. After the identification of that, the person or the individual, then will come with the refraction procedure. In the refraction, we'll evaluate the procedure, we'll evaluate the patients to determine what type of refraction is needed and the device may be required. So third is by the manufacturer. If the refractive correction is gained or it can be taken, then after for that refraction, with that refractive error or with that refractive correction, the spectacle is made and is provided to that individual. Then comes the dispensing, issuing of this that is spectacle or the devices. Follow up, that is a repair of the spectacle, devices, or the repeat dispensing. Vision 2020 envisages the following strategies. First is the strengthening the primary eye care programs within primary healthcare to eliminate preventable causes. Second, developing the therapeutic and the surgical support services to deal effectively with the curable eye problems. Third is the establishing the optical and the low vision services. So these are the strategies which envisages the Vision 2020. First is the strengthening the primary eye care facility programs within primary healthcare to eliminate the preventable causes, developing the therapeutic and the surgical support services to deal effectively with curable eye problems, and establishing the optical and the low vision services. The activities which includes first is the measles immunizations, vitamin A supplementations, nutrition education, and avoidance of harmful traditional practices, monitoring of use of oxygen in the newborns, provide specialist training and services for the management of the surgical for the management of the surgical remediable visual loss in children from congenital cataract, congenital glaucoma, corneal scar, and the retinopathy of the premature. So these are the activities which include these are the activities which helps in to combat the strengthening the primary eye care programs, which helps to eliminate the preventable causes. So these are the activities, right? These are the activities which helps in the corrections of the preventable causes of the blindness, like the measles, supplement immunizations, vitamin A supplementations, nutritional educations, and avoiding of the harmful traditional practices, monitoring of the use of oxygen in the newborn to prevent the retinopathy of prematurity, providing specialist training and the services for the management of the surgically remediable visual loss in children from the congenital cataract, congenital glaucoma, corneal scar, and retinopathy of the premature. Develop low vision services for visually handicapped children, promote school screening programs for the diagnosis and the management of the common conditions like refractive errors and trachoma in endemic areas, promote eye health educations in schools, ensure examinations of all children admitted in the blind school by an ophthalmologist. So the control of xerophthalmia is expected to be achieved through the Global Child Survival Program. So these are the activities which helps in the prevention of the preventable cause of the blindness. So now comes the human resources development. So the human resources development it includes community level, in which there comes the primary health care, that is a PHC, is a fundamental concept of the World Health Organization for the improvement in health. All the elements of the primary health care can contribute to the prevention of the blindness. PHC workers, that is, it has an important role to play in the control of blindness by identification. That is, PHC workers are ideally placed to identify the blind and visually disabled children and adults in their own home. Second, assessment and the diagnosis. PHC workers can be taught to assess those individuals who could be helped by the services of a specialist. For example, identifying cataract for the referral to an ophthalmologist, referral for the management and the treatment. That is, PHC workers can encourage individuals to go for treatment and can provide the referral system that will promote this. Fourth is a follow-up and the evaluations. After treatment, the PHC workers can follow up the patients at home to help with the visual rehabilitations. The patient after cataract surgery, for example, giving advice on any treatment and make sure that the spectacles are available. So the human resources in the PHC workers, that is at the community level, PHC workers will identify the identification, then the assessment and the diagnosis, then referral for the management and the treatment, or follow-up and the evaluation. Vision 2020, the right to sight in India. India was the first country in the world to launch the National Program for the Control Blindness, that is NPCB, in 1976 with the goal of reducing the prevalence of the blindness. Of the total estimated 45 million blind persons in the world, 7 million are in India. Due to the large population base and the increased life expectancy, the number of blind, particularly due to age-related disorders like cataract, is expected to increase. India is committed to reduce the burden of avoidable blindness by the year 2020 by adopting strategies advocated for the Vision 2020, the right to sight. The target diseases identified for the Vision 2020 in India includes cataract, childhood blindness, refractive error and the low vision, corneal blindness, diabetic retinopathy, glaucoma, and trachoma. So in India, cataract in the childhood blindness is the most common causes, which causes the blindness. Then the refractive error, and it also includes diabetic retinopathy and glaucoma, as the prevalence of diabetes and the glaucoma in India is very much. So the conditions, the diseases which targeted in the Vision 2020 in India, it includes cataract, childhood blindness, refractive error and the low vision, corneal blindness, diabetic retinopathy, glaucoma, and the trachoma. That is total. That only includes the human resources need. There is a need to develop. This is important. So there is a need to develop 2,000 service centers, each with 2 ophthalmic surgeons and 8 ophthalmic paramedics, like in hospitals. 20,000 vision centers needed to be developed, each with 1 ophthalmic assistant that in community or equivalent. Eye care managers will be required at the service centers. Community eye health specialists will be required at the training centers. Paramedics, mid-level eye care personnel. 2 streams of such personnel are envisages, like hospital-based, all categories like nurses, refractionists, ophthalmic technicians, assistant, theatre personnel, etc. Second, community and vision center based. These persons will be responsible for the school eye screening, refraction, primary eye care, and tonometry, etc. So in the 2 stages, that the paramedics, like in the level of the mid-level eye care, in the mid-level centers, 2 streams of the personals are needed. That is, first is the hospital based, and second in the community based. In the hospital based, we need nurses, refractionists, ophthalmic technicians, assistant, or the theatre, or the operation theaters. That these are the needed. These are the conditions which are needed in the hospital based. And in the community based or in the vision center, we'll need the person will be responsible for doing the eye and we needed to do the school screening, eye screening, refraction, primary eye care, and tonometry, like doing the intraocular pressure. Objectives for the year 2002-2007: to improve the quantity and quality of the cataract surgery. Second, development of the pediatric ophthalmology department in training centers and centers for the excellence. Third, to screen known diabetic for diabetic retinopathy in clinics and to screen more than 35 years attending the clinics. Means that to screen the known diabetic for the diabetic retinopathy in clinics means who are newly diagnosed, and to screen if there is a history of more than 35 years of diabetes. So to screen those diabetics who are newly diagnosed or who have known case of diabetes more than 35 years. Fourth is the low vision services to be initiated at the tertiary level with adequate linkage with secondary level and with primary care in a phased manner. Fifth, development of the safe eye banks and the networking of the eye donations and the training centers. So, 6 is the integration of the primary eye care with the primary health care throughout the country by training medical officers and ophthalmic assistants and other paramedical staffs. So these are the objectives in the year of 2002 to 2007. That is to improve the quantity and the quality of the cataract surgeries, development of the pediatric ophthalmologists in the training centers, and to screen the diabetic cases, and to introduce the low vision services at the tertiary level. And second is the development of the safe eye banks or the networking of the eye donations and the training centers. And last is the integration of the primary eye care with the primary health care throughout the country by training the medical officers and the other paramedical staffs. So these are the eye care infrastructure that is in the Center for the Excellence. It includes at 20 training centers, it includes at 200 in the service centers at the level of the 2,000 people, and the primary level vision centers and at the 20,000. infrastructure pyramid given above is based on the structure recommended by the World Health Organization. So this is the infrastructures which is uh, given by the which is recommended by the WHO. These are the days for the Center for the Excellence, that is it includes the 20 training centers, which includes the 200 people, and the service centers, which includes the 2000 populations, primary level vision centers, which includes the 20,000. Under the NPCB conference on primary eye care to support Vision 2020 was held on April 11 to 14, 2002 at Coimbatore. The participants included the members of the working group and the experts in the field of primary eye care in India. The recommendations of this meeting focused on infrastructure and support for the primary eye care, human resource development, and the training needs, models for service delivery, and the community participation. Infrastructure and support for the primary eye care, that is includes the vision center. Vision center in the primary eye care for populations of 50,000 in the rural area. Primary health centers, cooperative manned by the middle level of public personnel. The target is post one middle level of ophthalmic personnel per 50,000 population throughout the country by the 2020. This is the target of NPCR. To post one middle level of ophthalmic personnel per 50,000 population throughout the country by 2020. Function of the vision center. First is the identification and the referral of minor external eye diseases, example conjunctivitis, eye injuries, etc. Vision testing and prescription, dispensing of glasses. School eye screening program, eye health education, training of the volunteers, and identification, referral of cataract, glaucoma, etc. to service centers. So in the case of the second, that is a function of the vision center. First is the identification and the referral of the minor diseases like the conjunctivitis or eye injuries. But second is the vision testing and the prescription or dispensing of the or giving the correct refractive error corrections. School eye screening programs, eye health service educators like the training of the volunteers or identification, reference of the cataract or the glaucoma patients to the services centers. Personnel for the primary eye care, it includes to deliver the personal eye care. Following person will need to be involved. So for the primary health, for the primary eye care, following personnel is needed. That is area specific involvement of the volunteers from the local community, NGOs, 2 teachers from each middle school, health workers posted at the sub-centers and the PHC, middle level ophthalmic personnel, and medical officers at PHCs and the general practitioners. Examination process. Facilities for following examinations to be made available at each, that is vision center, to carry out functions of the PVC, that is torchlight examinations with the assistance of the magnifying loops, retinoscopy including the cycloplegic refractions, Shayad stonometry for the calculating the intraocular pressure, fundus examinations by the medical officers by the dilating the pupils. So support. The National Program for the Control of Blindness should provide following assistance to develop VC facilities like equipment at the vision center. So these that equipment is very necessary for the performing the eye care examination. So equipment, what equipments are needed? That is the trial set, trial frame, vision testing drum, plane mirror retinoscope, streak retinoscope, and the Snell chart. The Shayad stonometry for the intraocular pressure, torch for the batteries, lid speculum, epilation forceps for the case of the interning of the eyelashes. For removing that eyelashes, epilation forceps is needed. Foreign body spur or the needle for the removing the foreign body. Direct ophthalmoscope by the use of medical officers and the veterans. What are the drugs to be needed? That is cyclopentolate for dilating the pupil for the fundus examinations or for screening for the ROPs patients. What other drugs are to be needed? That is cyclopentolate, propicamide eye drops, 4% xylocaine for anesthetizing the eye, for the local anesthetizing the eye, ciprofloxacin, that is antibiotic ointment, chloramphenicol eye drops, 1% tetracycline eye ointments, ciprofloxacin eye ointments, neosporin artificial tea, or the oral vitamin A supplements and capsules. What are the materials to be needed? That is the blindness register, referral card for patient needing further evaluation of PHC, flip book for the eye health education, charts and posters, cataract card for the health workers. Spectacles free or the subsidy for the spectacles for the children between the 5 to 15 years and the affected patients. Human resources development and the training needs personnel to be trained in the PHC for the medical officers at the PHC, staff at PHC, sub-centers, school teachers, and the village level volunteers. So training needs assessment should be carried out after defining the job responsibilities of the above personnel. Village level activities could be contracted to local NGOs, self-help groups, and this would allow decentralizations to become a reality, and it would be a sustainable model. This could include optical cooperative unit. It is proposed to develop mobile primary care kit for the healthcare workers or volunteers. The kit may contain simple questionnaires on PEC, common eye ailments, simple tips on how to deal with the ailments. Eye care education should target the following, that is mothers regarding hygiene, nutrition and prevention of injuries, children regarding good reading habits, safety at play, teachers regarding the identifications of symptoms using simple checklists. Training on PHC should include DRIP training, 1 hour thematic training at PHC for transfer of skill related to the primary health care for health workers or village level volunteers, cascading training and training to function as a team. The training of teachers should include refractive errors, common eye symptoms, do's and don'ts. Training of the should include skills for vision testing, diagnosis of the operable cataracts, monitoring use of the spectacles. Need to develop modules for training different functionings. Orientations of the indigenous practitioners in the modern management should be undertaken for corneal ulcers, conjunctivitis, and dangers of harmful traditional medicines. The training should include recognitions of self-threatening symptoms and referral systems. Need to augment training capacity for the mid-level ophthalmic personnel. Mechanism for monitoring should be developed to assess the effectiveness of training at various levels. Referral and support system should be developed to link PC to the secondary and the tertiary level. Models for service delivery and the community participations. Childhood blindness. Pediatric ophthalmology facility should be developed at the tertiary level. Existing eye surgeons need to be trained in the pediatric ophthalmology. There may not be a need to create a separate post of pediatric ophthalmology at this point of time. Training of ophthalmic surgeons in pediatric ophthalmology for a minimum of 6 months at identified tertiary eye care centers. Support development of the pediatric ophthalmology team, including the pediatrician, anesthetics, or middle level of ophthalmic assistant personnel. In case a hospital is already doing pediatric ophthalmic surgeries, some support system may be required to develop pediatric ophthalmology facilities. Like equipment required for the pediatric ophthalmology need to be provided. Depending on the volume of pediatric ophthalmic surgery, decisions regarding setting up of a dedicated pediatric OT or providing adequate OT time may be taken. As more than half of childhood blindness is avoidable, emphasis should be given to prevent childhood blindness through cost-effective strategies. For the low visions and the refractive error screening within a specified period of admission to school should be done by schools in collaboration with the district blindness control society or district education department. So it is very important to control the low visions of the refractive error. So refractive error screening within a specified period of admission to school should be done by schools in collaboration with the DBCS or district education department. Address the organized sectors initially for screening and managing the presbyopia. Screening and services for refractive errors. Low vision should be integrated with cataract screening programs. Constitute a task force to develop strategies for the low vision services. Corneal blindness. Emphasis on the hospital retrieval system to get better donor material. There is an urgent need for assessment of number of people who would benefit by the corneal grafting. For vitamin A supplementation, we should focus on areas that are economically backward. Priority should be given to slum populations, tribal regions, drought and the flood-prone areas and the migrant populations. For the posterior segment disorders, medical retina services need to be developed in the tertiary eye care institutions. These units shall attend to various posterior segment disorders, primarily diabetic retinopathy. Awareness about diabetic retinopathy should be created in clinics managing diabetic patients. A small pamphlet on diabetic retinopathy needs to be developed for the physicians. So that they can give him the small pamphlet on the diabetic retinopathy. This is giving a pamphlet giving awareness to the society or the awareness giving to the populations or the community about the services provided in that area. So this is to give awareness to the community. Some inexpensive screening mechanisms for diabetic retinopathy should be established at the diabetic clinics. On a pilot basis, fundus cameras can be introduced in some clinics that are located centrally where diabetics can be invited to have free fundus photographs taken. So this is for the diabetic retinopathy screening. That is, some inexpensive screening mechanisms for diabetic retinopathy should be established at the diabetic center clinic. On a pilot basis, fundus cameras can be introduced in some clinics that are located centrally where diabetic can be invited to have free fundus photographs taken. Patients of age-related macular degeneration need vision services. Linkage needs to be established between the medical retina services and the low vision services. Advocacy and the public awareness. Various guidelines and the training manuals needs to be made available on the MOHWF website. Advocacy workshop should be organized involving the ophthalmologist and communication experts. Annual plan should list specific time-bound activities for the advocacy. Glaucoma information on the surgery for entropion trichiasis should be collected from the endemic areas to assess current situations. During the 11th 5-year plan, that is from the 2008 to 2013, the government of India has set out to achieve the goal of Vision 2020 and has set out the following objective for the next 5 years. First, to reduce the backlog of the blindness. So this is important. So during the 11th 5-year plan, that is from the 2018 to 13, the had set out to achieve the goal of Vision 2020 and set out following objective for the next 5 years. So what are the goals in the what are the goals of Vision 2020? So this is important. So just go through it. That is, what are the important goals to achieve in the Vision 2020 and the objective for the next 5 years. First is to reduce the backlog of the blindness, to develop comprehensive eye care facilities in all districts in the country, to develop human resources for providing eye care services, to improve quality of service delivery, with to secure participations of the NGOs in the national program. 6, to enhance community awareness of the eye care. So these are the 5-year plans, and these are the objectives, or these are the plans which are to be achieved in the Vision 2020 and which is said to be the following for the next 5 years. What are these? First is to reduce the backlog of the blindness. Second, to develop comprehensive eye care facilities in all the districts in the country. To develop human resources for providing eye care services. 4, to improve quality of service delivery. and to secure participations of the NGOs in the national program and to enhance the community awareness of the eye. Okay, so this is important. Hope you understood. So in this, the comprehensive that is community ophthalmologies. In this, only the what is blindness. So, okay, the different type of blindness, what are the different type of blindness and their definitions is important. Vision 2020 is important, and what are the programs are included in the NPCP are important. Okay, so in this you have to go through, and the many multiple choice questions come in from this question, from this topic, and also the short note also come from this topic, like Vision 2020. If the question comes about what is Vision 2020, the right to side, you have to write everything. What is Vision 2020? What are the programs are included under the Vision 2020? What are the strategies? What are the diseases are included in the Vision 2020? And what are the goals of Vision 2020? Okay, so these 5 criteria consist of Vision 2020 and it completes the question. So long question can also come on the Vision 2020. Okay, if any questions or any doubt, you can ask me. Okay, so thank you.